being new to this, I wasn't quite sure what I'm supposed to say. So what I'm going to start with is I'm just going to talk a little bit about, who I am, what we do, and then if people want to ask questions, I would be very happy to address them for you. So I'm a physician, a reproductive endocrinologist who is specially trained to help people who have infertility. So that's my background. And so we have all the technology, primarily IVF and donor eggs and surrogacy, that we have used historically for treating heterosexual couples who have infertility. But we can use the exact same technology that we have for treating infertile couples for helping gay male couples have children as well. And so, as I mentioned in my introduction this morning, I have been in Boston since about 1993 in the same practice. And I've been treating gay male couples since 1998. And the vast majority of the male patients that I see who come to me have been coming from word of mouth referrals, which means that they tell their friends and they tell their friends and all that, and so that's how they've come. I have treated patients internationally. I've had patients from Europe, again, all by word of mouth. I'm actually seeing a couple from Hungary next week or 2 weeks from now, and they were referred by another couple from Hungary that I treated several years ago. And I've treated people from Italy, from France, from the UK. I've treated people from South America, from Canada, and all have been referred by referrals, and also mostly in the US. And I would say that the vast majority of my patients are people in the New England area or in the Northeast. As I said, I've treated patients going back to 1998, and so I can tell you some of the success rates that we've had based on the total experience that I've had going back almost 20 years. And the thing to keep in mind is that when I was treating male couples back in the late 90s and early 2000s, around the turn of the century, the IVF success rates were not as good as they are now. There has been significant improvement in the success rates, and things have changed a lot just within the last 5 to 7 years in terms of success rates. But in quoting you success for the total experience dating back to when I first started, I can say that 100% of the patients that I've treated, these are just male couples using egg donors and surrogacy. 100% of them have been successful if they go through the treatment. And I still have people who are, getting ready to cycle that are not counted in those statistics. And based on my total experience, almost 20 years, 100% of those couples who have actually gone through the treatments have taken home a baby. They've been successful. 73% of them were successful with their first attempt, first embryo transfer, and the rest required a second embryo transfer, mostly frozen embryo transfers, to have a success. And I've only ever had one couple in my entire career of treating gay male couples who have required a third attempt to actually have their baby. So I think that that's pretty good. The fresh transfers, we're seeing about a 75% pregnancy rates, and this is a combination of transferring 2 embryos and 1 embryo. With frozen embryos, we're seeing about 59% pregnancy rates, slightly lower. Most of those were with the older technology of freezing. We now have a newer technology of freezing where the success rates are also much better. And in looking at double embryo transfers, so historically we used to transfer 2 embryos frequently, but now we're trying to do more and more single embryo transfers because we have found that twin pregnancies are complicated pregnancies, and especially for surrogates, it can be complicated. So when we looked at our success rates for double embryo transfers, Anytime we transfer 2 embryos, we're having about a 73% success rate. And when I say success rates, I mean live birth, not just saying pregnancies. And when we do, so more recently, I would say within the last 6-7 years, we've been shifting towards doing more and more single embryo transfers. And we look at just the single embryo transfers in the more recent years, we're getting about an 81% live birth rate. And that just shows you that the technology has changed to the point where we can confidently transfer single embryos and get very good success rates as well. The other thing is looking at the twin pregnancies. If you look at double embryo transfers in the fresh embryo transfers, when we transfer 2 embryos, we're seeing about a 45% twin birth rate. And with the frozen embryos, when we're transferring 2 embryos, we're seeing about a 33% twin birth rate. So again, all of that is to tell us that twin pregnancies are complicated, and we're now shifting away from doing that and focusing on doing single embryo transfers. So that's our experience. I have a team working in my clinic that is a totally dedicated to our donor egg program. And our donor egg program is not just for gay male couples or gay men, but it is for everybody doing donor egg and surrogacy. And so they have been intimately involved with all the donor egg processes and the surrogacy processes, and they, of course, then take care of all of my gay male patients as well. And so I think that one of the important things for you when you're looking at which clinic to work with, I mean, there are many different factors. One of them is the experience of the clinics and whether or not they have people who can are experienced in treating gay men, and the way that they can handhold you through. So I would say that virtually all of the patients that I've treated, going back almost 20 years, none of them have been through a Men Having Babies conference. So they come in just totally unprepared, and we just walk them through the process and teach them everything that they need to go. So you are way ahead of them because you've already learned a lot more than my patients have. And as I said, this is the first time I've been to a Men Having Babies conference, so this is all new to me as well. Without going any further, I don't want to keep talking, but I do want to ask you if there are any specific issues or topics or concerns that you have that you'd like for me to address, and I'd be happy to talk about that.
So does your clinic have a database for egg donors?
Yes. Yes and no. We work with frozen donor egg banks, and so if you are looking to use frozen donor eggs, we have that for you. But we are not a donor egg agency, so if you're planning to use a fresh egg donor, then what we do is we will give you information about some of the donor egg agencies that you can go to search for a fresh egg donor. Historically, most of our cycles were with fresh egg donors, so what we would do is we would have an egg donor synchronized with a surrogate, and we would transfer 1 or 2 embryos, and if there are any extra embryos, the extra embryos can be frozen for future use. And if people don't get pregnant with their first transfer, they come back and we can do frozen embryo transfers until they get pregnant. If they do get pregnant, typically, historically what we used to do was we used to transfer 1 embryo from each of the 2 men, and if they got pregnant with twins, they have 1 child from each of the genetic fathers, and if only one of them takes, then after birth we figure out which is the genetic father, and they would come back and use a frozen embryo from the other cohort to have a genetic child from the other partner. That's what my husband and I did. We have a 12-year-old and an 8-year-old from this exact same process. But when we were doing the transfers back in 2004, I guess, when I was doing this, we were transferring 2 embryos from 2 men. But we've kind of stopped doing that. The men who are doing it now are typically freezing all the embryos from one cohort, transferring one, and then they come back and transfer one from the other. Yes?
If we have a known surrogate, do you have a policy on, do we have to work through an agency, or do you require us to work through an agency, or is that to our decision?
Well, we require that you work with an agency for the coordination and the legal paperwork, because you can't really do this without the coordination and the legal paperwork, because there's a lot of legal documents. You know, at the end of the day, you're going to have 17 legal documents, and this is not something that you can handle on your own. The agencies, some of the agencies, at least one of the agencies that we work with, typically have what they call they don't match you, but they can coordinate they can administrate all the paperwork and the legal documents for you. And yes, we do require that you have somebody do the legal paperwork and coordinate the cycle, the journey, if they want to call it that. But it's really not something that you can do on your own, right?
So for the frozen egg donors,
Yes.
it's going to be much quicker than fresh one?
Yes, it is. The frozen egg is a very different thing, because when you use a fresh egg donor, you get all of the eggs from that egg donor. Whether they get 15 or 20 or 25 or however many eggs, they're all your eggs. With the frozen eggs, what we do is you get a lot of 6 to at most 8 eggs per treatment. And so you're starting out with fewer eggs. You typically end up with fewer embryos. You may end up with only 1 or 2 or 3 embryos, as opposed to the fresh cycles, where typically you end up with half a dozen or more embryos. If you are planning to have 2 genetic fathers, and you're dividing the eggs into 2 groups and inseminating 2 groups, it makes more sense to use a fresh egg donor, because if you start with 6 eggs and you divide it into 2 lots, you only have 3 each, and that's not as good. So we don't recommend it. If you're only 1 genetic father, then that makes a lot of sense, and we've actually done that. I have some data on that. We have had 9 cycles within the last 4 years who have used frozen eggs, and 8 of them were successful. So that's about an 89% success rate. But those were all cases where they were using just 1 genetic father.
So right now the technology, both frozen and fresh have the same results, right?
The success rates are pretty much similar. If you transfer a blastocyst derived from frozen eggs and a blastocyst derived from fresh eggs, and you transfer 1 and 1, the likelihood of implantation and successful pregnancy is very similar. It's about the same. The difference is that if you don't get pregnant and you need to do more, or if you have 2 genetic fathers and you want to have more embryos, then you may end up at a disadvantage, because the cumulative success rate will be lower with the frozen compared to the fresh.
One more question.
Yes.
So frozen eggs have more choices than fresh, without
Yes.
exceptions?
Right. So just the egg bank that we work with, and there's different frozen egg banks. The egg bank that we work with in our clinic has over 100 egg donors on the list. So yes, you have more to choose. And the advantage of that is that it is ready to use. So whenever you have your surrogate ready, you pick your egg donor, we thaw the eggs, we inseminate them, we create the embryos, and you're ready to go. And it avoids the need for synchronizing the cycles with a fresh egg donor. But the other thing is that we are seeing a lot of gay men now. What they're doing is they're coming in with their egg donor first, creating all the embryos and freezing them, and then when they get their surrogate, 8 months later or a year later, then they come back with their surrogates to do the frozen embryo transfer at that time.
And then your clinic screen the egg donor?
We do all the screening, yes. We do the medical screening, we do the infectious disease screening, we do genetic screening, we do health screening, we do drug screening, everything. It's a very standard panel.
For either frozen or fresh.
Yes, they're all exactly the same. And in fact, even when people bring in a known donor, if you bring in a known donor like your friend or a sister or somebody to be an egg donor, they go through the exact same screening process. There's a fairly standard way of screening egg donors.